Okay, so the Power Study was a large health equity report for the province of Ontario, and we took a comprehensive look at a whole host of indicators for the leading causes of morbidity and mortality in the province, and our indicators spanned clinical care as well as population health. So actually, we used a very community-engaged process. We convened roundtables of a wide range of stakeholders. So we had policymakers, we had decision makers, we had people from the hospital sector, from primary care, from public health, from community organizations, from the government, and we discussed about what would be the most important things and what were the most both what were the most important issues to report on, as well as within those issues, what were the types of things that we should be looking at. Actually, it was really surprisingly easy. I think that people felt a huge need to do this, and I think the added benefit was that people are working a lot on these different issues in their own sectors, but there's not a lot of cross-talk. So I think one of the things, the side effects of what we did was bringing people together where they really had a chance to compare notes and think about ways that their work was synergistic. I think so. It's hard to tell because, interventions happen in local communities. But I do think it started different sorts of conversations that hadn't happened before. So we used a wide range of data. We used any data we could get our hands on, and a lot of the work was in terms of getting access and being able to use the data and then learning the data sets and their strengths and limitations. But we used, in Ontario, we have very good administrative data on the population based on the health system. Our health insurance plan is called OHIP, the Ontario Health Insurance Plan, so we're able to get all kinds of data from that on visits and hospital utilization and population-based denominators. But then, that was not sufficient. We also use survey data. So we use data from the Canadian Community Health Survey. We use data from a provincial survey, the Primary Care Access Survey. We used disease registry data. There's a stroke registry in the province that does health audits. We used vital statistics data. And we also did some innovative data linkages to try to look a little bit closer at things that have, I'll give one example. So when we looked at rates of screening for cervical cancer for Pap smears, we found an income gradient, even though everybody is covered, and we found regional differences where low income and immigrant women were much less likely to be up to date or have been screened for cervical cancer. But then we took it the next step and we linked it to pathology data where we had actually the results. And then we looked at whether, we didn't look at people who had like really serious abnormalities because we assumed they would be followed up, but we looked at people who had kind of moderate abnormalities that required, rescreening or another diagnostic test and looked to see if they were followed up in the recommended time frame. And what we found was that a surprisingly large percentage of women weren't getting followed up even after an abnormal PAP. So that even if your indicators look good for screening rates, if the screening isn't acted upon, you're not actually accomplishing your desired outcomes. And actually that led to Cancer Care Ontario in the province has now a large under-screened, never screened intervention across the province reaching out to women who are at risk for not getting screened. But they've also done work to make sure that people, once they get the results, get, structured follow-up. We actually, the last report we did was called Achieving Health Equity in Ontario, synthesizes all of our work. So there's short couple of paragraphs on the findings from each of the reports and really pulled out the common themes. And we think there were a number of important themes. I think, first of all, that health equity is really key to sustainability of health systems. I mean, if you want health systems to thrive and be fiscally solvent as the population grows and ages, you really need to promote health. So, and I think that you can, and that all efforts to improve quality in health systems really need to focus on health inequities, and there's a lot of benefit in doing that. I think the other thing we found was that measurement is important, but that gender inequity analysis needs to be really just central to any kind of quality improvement programs within health systems for performance measurement and monitoring, because otherwise you're going to miss differences. The average will mask populations where you're not performing well and require interventions. And I think, the biggest message that came out is just the need for more integration, both within the health system, across public health and health care, and with social services, and really having comprehensive community-based approaches to improving health. Yes. So I think one of the important things that we know that risk, and the determinants of health are multidimensional. And the reality is that gender interacts with all of the determinants of health, like income, education, ethnicity, geography, where you live. So, and there's multiple groups that are vulnerable in society. And I think it'll vary from community to community, from country to country, but people need to define those groups and measure health for those. But and the other thing we found was that doing a gender analysis really is good for both men and women, because men are vulnerable and have shortcomings in other areas. For example, women have more disability, men are more at risk for premature disability. But even in things like osteoporosis and hip fractures in the elderly, we found that we're not doing good when older women fall and break a hip. Many of them don't get screened and treated for osteoporosis. But if you're a man and osteoporosis is a problem for men, you're even less likely. So I think it really just showed the value that if you, and I think in terms of interventions, you need to target interventions to those populations at the greatest risk, or sometimes you need different types of interventions to be effective in different populations. So I think indicators provide a guidepost where you can actually track what, you have a baseline, you see how you're doing, you see where the needs are. It can help people prioritize. But then as you do interventions, you can use them to see whether your interventions are working or not, or whether you have to change course. I think that's where we are now. I think the evidence is thin on what interventions really achieve health equity. But I think we need to be very cautious, because some people use that as an excuse that we don't have the evidence, so we don't know what to do, so we can't do anything. And that's absolutely not the case. I think the literature is full of interventions in different communities that have made a difference, both within health and health care and within terms of addressing disparities. I think what we need to do is design interventions based on input from the community and understanding local context with the best evidence available, and then implement them in a way that they could be rigorously evaluated, so that we could learn what works for who and what settings, and then learn how to build the evidence from these types of interventions into something that we can scale across a system. I think in the ideal world, well, first of all, we know there were limits to our data, and there's always risks that, you focus on what you could measure, and that there might be many other things that you can't measure that are equally, or if not more important. But I think we were important to put it in context where we clearly set out and said what we couldn't measure. And we did provide context with input from the community on what the measures meant. I think that there were lots of things we couldn't measure because the data is limited. Limited data on certain populations because of sample sizes, things that we don't collect. We don't have a lot of data, especially in Canada. Here you have much more on primary care, on care delivery within the primary care system. But I think what I would have liked to have seen is we had developed the core set of equity indicators, and it would have been great to see those actually incorporated into a provincial monitoring structure where people and develop some priorities and accountability for change, and really use them as kind of a catalyst or a fulcrum to be able to improve health in the province. And that's something that has not happened. Our project was unique on 3 dimensions. The fact that we first stratified by gender and then by the determinants of health. The fact that we covered, we kind of bridged both population health and health care, and also looked at the social determinants of health. And the fact that we used a community-engaged research approach. And it was an integrated knowledge translation strategy so that we could, and that helped the dissemination. So a lot of our work is being used currently now by local health integration networks, public health units, hospitals, family health teams, so community health centers. So we did get wide pickup, but locally, not at the federal level. Across Canada, Manitoba has done a lot of interesting reporting around health inequities. So there's been sporadic different types of reports, but there's no structured process to do equivalent reports. And one of the challenges of federal system is that data varies a lot across the different provinces. Right now, though, there's a lot of interest in the national level, and I'm actually on 2 expert panels, one from Health Canada and one from the Canadian Health Information Agency, where they're doing health equity reports, where they're trying to get comparable data across Canada. One is going to look at trends over time, and one's going to drill down more on different populations and how they're doing in Canada. So I think those reports are going to be very important for the national agenda. Well, one of the things I could say about, I'm thrilled that I've been able to, come to Scotland and learn about the work of the center and other work that's going on in Scotland. And I think that one of the things is because we don't have the answers, there's just huge opportunities for learning across borders. And I think that's one of the things I would love to see in the future, is just more collaboration across different countries around these solutions, and communicating, about what interventions work, what methods work in terms of measurement and evaluation. So I think that's coming. I think in the future there's some of that, but I think there's going to be a lot more of that in the future.